நான் வேற என்ன பண்றது? இதெல்லாம் தான் நமக்கு சொன்னாலும் புரிஞ்சிக்க மாட்டானுங்க. முதல்ல சொல்றது பெஸ்ட். Good evening, doctors. Welcome to this live discussion. Now, if you could hear me, please do let me know in the chat box. Am I audible, doctors? People, am I audible? Okay. Anyway, it's not coming. Yeah. So, all right, doctors, let us start with the, excuse me. So, people, welcome again. Let us start with the questions that's been asked in FMGE 2022 June paper, guys. So we tried our best to collect all the questions possible, and so far we have had some 6 to 7 questions, people, and for those questions also few options are missing, but anyway the point is we need to know what is the correct answer for all the known questions, and with the questions that are missing, I sincerely request you guys to send the questions and options if you could able to remember, so that it will be very helpful for your juniors as well. So yeah, let us get these 6-7 questions right and the answers for those questions and the discussion part of those questions, so that you can use it for these upcoming exams as well. So before taking much time, now let me start with the questions and let me start with the answers, doctors. What we'll quickly see all those answers, and then we'll come back to the discussion part, so that you'll be familiar with the answers again. Question number 1. What is the change in efferent arteriolar resistance with related to increase in osmotic pressure? What happens to efferent arteriolar resistance with increase in osmotic pressure? The answer is option C. Option C is the right answer. Efferent arteriolar resistance increases by 4 times. Next question. Insulin stimulates glucose uptake by cells via GLUT4, and that is an example of A. primary active, B. secondary active, C. simple diffusion, D. facilitated diffusion. The right answer is option D, facilitated diffusion, doctors. That's the right answer for second question. Coming to third question. Most common macrocytic anemia in India. Alright, and we are not having the right answer, people. Cideroblastic anemia, alcohol, thalassemia, and we don't know the fourth option. So the answer for option question number 3 is alcohol here. Most common macrocytic anemia in India is going to be alcohol. And question number 4 as well as question number 5. Question number 4 as well as 5, people. Now we are not sure whether two separate questions have been asked or it is the same question, and some of our students who told us this discussion maybe they might have missed certain things. So I'm not sure whether the data is coming from a same question or different question, but whatever it is, let us get to the answers here. For question number 4, pH 7.28, bicarbonate 28 milliequivalents, carbon dioxide 70, the answer is respiratory acidosis. Option A, it is respiratory acidosis, people. Now coming to question number 5, patient continuing with pH of 7.23, PCO2 60 millimeters of mercury. Rather than bicarbonate value, here its saturation of hemoglobin is given, and they have given saturation of hemoglobin as 82%, and the diagnosis is supposed to be respiratory acidosis again. For this question also it is going to be respiratory acidosis. So I don't know, people, whether both are coming at the same question or different. Yeah, some of you are saying it's different. Anyway, we'll see that. So coming to question number 6, pancreatic cell tumor leading to secretory diarrhea is option A, VIPoma. That's the right answer for the question. So Dr. Himanshu was answering here. It's 2 times not 4, and option D is chronic infection. So let's try to incorporate your answers here, people. So most common macrocytic anemia, option D is, Dr. Manoj was saying this as chronic infections. Thank you, Dr. Manoj. Thank you very much, Dr. Manoj. So it's chronic infection, and yeah, for the question number 1, they have Dr. Himanshu was saying it's 2 times not 4. So let's take it increased by 2 times, decreased by 2 times. So but still in this case it is going to be increased by 2 times, doctors. So maybe it's going to be 3 times, but still 2 is the best answer for this question. So yeah, again Dr. Himanshu was saying only one question of respiratory acidosis. Yeah, anyway, people, so let's simplify this. Coming to the questions on respiratory acidosis, so let's try to incorporate both into same questions. Anyway, let us get to the discussion part. Now I hope you are familiar with the answers for all these questions, and without wasting time, let us get into the discussion part. Yeah, so Dr. Faizan was saying question second, which does not cause microcytic anemia. Okay, so let's incorporate that too as well. So which does not cause microcytic anemia. Alright, so let's have this question, which does not cause microcytic anemia. Even if it is this case, alcohol is going to be the right answer, people. We'll come to know the discussion part, we'll come to know the answers in a very detailed way during discussion. So that's our physiology questions. Let us get to the discussion part, people. Image was given of glucagonoma. All right, Dr. Faizan, if you could able to get me that image, it will be of awesome help. Even if it is not possible, that's okay. I'll try to bring it up the image, and we'll get to that image based discussion in a separate part. But as of now, let's get to the discussion part, doctors. So let us take up the very first question. What's the change in efferent arteriolar resistance with related to increase in osmotic pressure? Now, guys, this is a kind of question which incorporates or which integrates two different pathways, two different systems altogether. Number one, endocrine. Number two, renal physiology. All right. So such kinds of questions has not been asked in FMGE so far, but if the questions are coming to this standard, it is indicating one point very definitely, which means you guys are not supposed to stop with preparing FMGE questions alone. You are expected to prepare neat questions as well, because the standard of this question is supposedly slightly higher than what a FMGE paper usually gives to you. Now anyway, let us get to the discussion part here, people. What's the change in efferent arteriolar resistance? Now let us take up a glomerular capillary. We have afferent arteriole turning into glomerular capillary as well as efferent arterioles. We take this afferent arteriole and we take this as efferent arteriole, people. Now they are asking about osmotic pressures. That's the key word here. What happens when osmotic pressure rises? Now, what is this? What is osmotic pressure? Osmotic pressure is something that is getting exerted by. Osmotic pressure is exerted by number of solute molecules. Number of solute molecules. Alright. So these solutes will attract water. The solutes will attract water, and the force of water attraction by a solute is what is called as osmotic pressure. That attractive force of a solute over a water molecule is called as osmotic pressure. Now in a solution, people, if you take up a solution, you have two components. Number one is solvent, number two is solute. So a solution is made of two components, solvent as well as solute, doctors. Now in what condition you will have increased osmotic pressure? So between solute and a solvent. Now in a solution, guys, in a solution, if the concentration of solute increases, and when the concentration of solvent decreases, right? When the concentration of solute is very high than the concentration of solvent, this indicates a condition like dehydration. Dehydration or any cases of fluid loss. The solvent is lost more than the solute. In such case, when the quantity of solute is apparently increased than the quantity of solvent, there is going to be increased in osmotic pressure. Because of excessive solutes, there is going to be an increase in osmotic pressure. So practically this is called as hyperosmolality. Hyperosmolality. Whenever blood becomes hyperosmolar, the immediate next step is there is going to be stimulation. There is going to be stimulation of osmoreceptors in hypothalamus. Stimulation of osmoreceptors in hypothalamus. Friends, this is another entrance question. What is the osmoreceptor which is located in hypothalamus? Osmoreceptors is nothing but a region called organum vasculosum, lamina terminalis, abbreviated as OVLT. That region in hypothalamus is called as osmoreceptors, which is involved in sensing the osmolality of blood. Now, whenever blood osmolality rises, what will happen? This increased osmolality, increase in blood osmolality, is going to trigger the region called organum vasculosum lamina terminalis. This again stimulates. This again stimulates a region called supraoptic nucleus as well as paraventricular nucleus of hypothalamus. Supraoptic as well as paraventricular nucleus of hypothalamus. Now this ultimately leads to release of a hormone called antidiuretic hormone. Antidiuretic hormone, also called vasopressin. You guys know very well, antidiuretic hormone is also called as vasopressin. Alright. Now this hormone vasopressin is going to influence, the hormone vasopressin is going to influence, or it is going to trigger contraction of blood vessels. The name itself tells you it's going to contract blood vessels, and efferent arteriole is no different. So there is going to be contraction of efferent arteriole. Alright. When efferent arteriole contracts, alright, what happens to resistance? That's the question, people. When efferent arteriole contracts, obviously you know that when it comes to resistance, alright, resistance in a blood vessel is contributed by, number one, viscosity of blood. Number two, multiplied by length of blood vessels. While viscosity of blood and length of blood vessel is directly influencing the resistance, which means when the viscosity increases, length increases, resistance parallelly increase, and it is inversely related to radius to the power of 4. It is inversely related to radius to the power of 4. This equation, which corresponds to these three factors, viscosity, length as well as radius to the power of 4, this equation is called as Hagen-Poiseuille's law. This equation is called as Hagen-Poiseuille's law, doctors. So with contraction of efferent arteriole, what will happen to the radius of that blood vessel? We have radius decreasing. When the radius of a blood vessel decreases, you know what will happen to resistance? When the radius falls, it is indirectly related to resistance, so we will be expecting an increase in resistance, doctors. So the best answer for this question is, if there is no specific data given regarding the measurement of radius of efferent arteriole, you got to consider this. Whenever radius falls by 1 time, resistance increases by 4 times. When radius falls, resistance increases. So when it comes to the question, people, if you have option 4, if you have the number 4 in question, that is going to be the best answer. If there is a question with option that is increased by 4 times, that is going to be your best answer, people. But as Dr. Himanshu was saying, if that is not given, alright, if that is not given, you got to go for the best answer, that is going to be option A, increases by 3 times. Alright, so let me emphasize this. The best answer is resistance increases by 4 times. Resistance increases by 4 times. If 4 is not given in your question, so you have to go to a value which is very close to number 4. Now, as some of you were saying, if 4 is not given, and 2 alone is given, so you got to go for the second best choice, that's going to be 3 times people. So we can say resistance increases by 3 times, because that's going to be a very closer value to option, the right answer, that is 4 times. So please understand, you have a vasoconstricting effect by by antidiuretic hormone, that is vasopressin. Because of effect of vasopressin, the radius of vessel decreases and resistance increases. That's the answer for question number 1. All right. So let's take up the next question, people. So before we go to the next question, if you got any doubts in question number 1, please do type here. I'll see to that you have you understood the question 1 clearly. All right, so we have the next question. Enzyme causing conversion of T4 to T3. Okay, we'll add that. Okay, posterior pituitary and oxytocin. All right, we'll come to that. Fine. Okay, people, that's good. So that is question number 1. Now let us move on to question number 2. Insulin stimulate glucose uptake by cells via GLUT4, which is an example of. It's a very simple question. The right answer for this question is option D, that is facilitated diffusion. Now you'll know the basic difference between different kinds of transport, doctors. When it comes to transport across cell membrane, transport across cell membrane can be divided into 2 types. One is passive transport and the second one is active transport. Passive as well as active transport. Active transport have got 2 subtypes. You can able to have primary active transport as well as secondary active transport. Primary active transport involves breakdown of adenosine triphosphate, while secondary active transport is dependent on primary active transport. All right. Coming to passive transport, people, again we have 2 types of passive transport. First one is simple diffusion and the second one is facilitated diffusion. Simple as well as facilitated. Now we have a direct explanation about this question in our notes itself, people. So if you need, you can check up the notes also. When it comes to diffusion, guys, you take up this way. Simple diffusion, you need to know certain points. Simple diffusion involves no carrier transport or no transporting proteins. There are no transporting proteins involved. All right. So without any specific transport protein, molecules move from high concentration to low concentration. High concentration to low concentration, that's simple diffusion. Number 3, simple diffusion is usually seen predominantly for gas molecules because gas molecules are non-charged molecules. They don't have any charges. They are non-polar molecules. So simple diffusion will be carried out by either a non-charged as well as non-polar molecules alone. There is a law that governs simple diffusion, which is nothing but Fick's law of diffusion. The law that governs simple diffusion is Fick's law, doctors. Fick's law of diffusion. Good. Now you know what is Fick's law of diffusion. This stands for rate of diffusion, which is directly proportional to surface area of membrane as well as concentration gradient, and it is inversely proportional to thickness of membranes. All right, these are all the points you need to be familiar about simple diffusion. Now when it comes to facilitated diffusion, people, facilitated diffusion do involve a carrier molecule, and this carrier molecule is specific for each solute. It is very specific for each solute. And being facilitated diffusion, this is also happening from a region of high concentration to a region of low concentration. The solutes move from a region of high to low concentration. And you guys know that the transporter GLUT4, is a glucose transporting molecule which is specific only for glucose. Alright, which is why this is a glucose transporting molecule specific only for glucose, and hence it moves glucose from a high concentration to low concentration. So this is a clear-cut example of facilitated diffusion. So guys, you know the difference between simple diffusion as well as facilitated diffusion. On the other hand, when it comes to glucose transport, you also need to know another point here. When it comes to glucose transport, let us consider two sides of a cell membrane. One is luminal side of a cell membrane. On the other side, we also have basal side of the cell membrane. Luminal side as well as basal side. Usually people, when it comes to intestinal epithelial cells or proximal convoluted tubule cells, you have on the luminal side, you have a transporter which is going to involve transport of two solutes together. One is sodium and the second one is glucose. Sodium and the second one is glucose. This transporter is called as sodium dependent glucose transporter, SGLT. SGLT have got two subtypes, SGLT1, SGLT2. SGLT1 is predominantly seen in gastrointestinal tract, especially in jejunum, while SGLT2 is located in proximal convoluted tubules of nephrons, PCT of nephrons. Both SGLT1 as well as SGLT2 belongs to a kind of transport called secondary active transport. Secondary active transport. On the other hand, if you consider the basal membrane has got a unique transporter called GLUT2, people. GLUT2. It is not GLUT4. Please understand, this is GLUT2. And GLUT2 is involved in transporting glucose out of the cell into the interstitial fluid. GLUT2 belongs to facilitated diffusion. Facilitated diffusion, doctors. Now coming to GLUT4. Again, as we just discussed, GLUT4 belongs to facilitated diffusion way of transport. GLUT4 is seen in number 1, adipocytes. Number 1, it is seen in adipocytes. Number 2, it is seen in skeletal muscles. Number 3, it is seen in cardiac muscles. So predominantly, GLUT4 is present in adipocytes, skeletal muscles as well as cardiac muscle. The uniqueness of GLUT4 is the transporter which is triggered by the hormone called insulin. So insulin practically upregulates the number of GLUT4 molecules on cell membrane, thereby glucose uptake into the cells are facilitated by insulin. Alright guys, so that's our question. Insulin stimulates glucose uptake by cells via GLUT4 is an example. Answer is facilitated diffusion. Good. Now if you have any doubts in question number 2, please do share it in the chat box. I'll answer the question at the end of the discussion, people. If not, let us go on to see the third question. Let me take up the third question here, people. Most common macrocytic anemia in India. Alright, if not, if this is not the right question, and some of you, I think Dr. Himanshu was saying this, which does not cause microcytic anemia. Now, whatever it is, let us get to see the options here. You need to know each and every options here. When it comes to the question, let us take up the answer first. Cideroblastic anemia, alcohol, thalassemia, chronic infection. It can be either of the way. Most common macrocytic anemia, or which does not cause microcytic anemia. I am not sure what is the exact question asked in your exam, but still my dear friends, understand this. Whatever it is, the right answer for this question is option B, alcohol. Alcohol is the right answer for this question. Let us start with the option sideroblastic anemia. Let's get to see what is sideroblastic anemia first. Now, during erythropoiesis, alright, during erythropoiesis, alright, during erythropoiesis, there is going to be abnormality in iron metabolism. There is an abnormal erythropoiesis where there is going to be an abnormality in iron metabolism. So the enzymes involved in iron metabolism can become abnormal, leading to abnormal iron incorporation into heme or abnormal iron transport into mitochondria. In whatever the condition it is, there can be a genetic enzyme deficiency of iron processing within developing erythroblast, or there can be a iron processing enzyme abnormality in mitochondria. Whatever it is, within RBCs, we can able to see free iron. We can able to see free iron, doctors. Now, you know very well, within a red blood cell, iron is always seen attached with porphyrin ring. So, in a normal RBC, iron is always seen attached with porphyrin as heme. Alright, I hope you get this idea. Iron Fe2 plus, iron plus porphyrin. Iron plus porphyrin is called as heme, and this is what is present in a normal RBC. This is what is present in a normal RBC. Whereas in cases of abnormal RBCs like sideroblast, you take up this sideroblast, it will have an RBC and there is going to be deposition of iron around the nucleus. It is an immature RBC, people, which is why it still has got nucleus in it, and around the nucleus we could able to see iron in a ring shaped manner. These ions are non-heme ion. They are non-heme. They are non-heme ion. Very important. Alright. So this non-heme ion present within the RBC cytoplasm surrounding the nucleus, such kinds of cells are called as sideroblast. Such kinds of cells are called as sideroblast. Now, when it comes to sideroblastic anemia, regarding to this question, I am saying, doctors, sideroblastic anemia can produce two kinds of cells. Alright, if the sideroblastic anemia is congenital, this will produce microcytic anemia. or if the sideroblastic anemia is acquired, it will be macrocytic anemia. So, in a same diagnosis, in a very same diagnosis, sideroblastic anemia, you can able to see macrocytes, also microcytes. Depending on the mutation, depending on the enzyme that got affected, the condition, diagnosis, sideroblastic anemia can be seen with both microcytic cell as well as macrocytic cells. So, applying this knowledge into the question, is it a very common condition? Absolutely not. Cideroblastic anemia is not a common condition. So if the question is most common macrocytic anemia, sideroblastic anemia is not the right answer. If the question is which does not cause microcytic anemia, again sideroblastic anemia is not the right answer because it will cause microcytic anemia. Alright. So in either of the condition, option A is ruled out. Let us take up alcohol. It's a very interesting manifestation, how alcohol causes abnormality. Number one, with chronic alcoholism people, with chronic alcoholism, there is going to be B12 deficiency. There is going to be folate deficiency. Number three, alcohol itself is toxic. Itself is toxic to bone marrow. So there is going to be abnormal erythropoiesis. There is going to be abnormal erythropoiesis. So in chronic alcoholism, you could able to see three kinds of condition: B12 deficiency, folic acid deficiency. It itself is going to cause abnormal erythropoiesis. And number four, you know very well, chronic alcoholism is associated with liver disorders. And this leads to abnormal lipoprotein and lipid metabolism. Abnormal lipid metabolism. Now, because of abnormal lipid metabolism, there is going to be excessive cholesterol in blood. There is going to be increased cholesterol in blood. And this increased blood cholesterol deposits on RBC membrane. It deposits on RBC membrane, enlarging the size of RBCs, leading to macrocytes. Friends, I want you to understand the very first point here. Alright, when it comes to macrocytosis, please get to this point. It is a well-grown, well-developed cell. Alright, macrocytosis is a well-grown, well-developed cell. Fine. And this is not a immature cell, this is a well-grown, fully developed cell, but the size of the cell is very high. On the other hand, if you consider B12 deficiency as well as folic acid deficiency, in these two conditions you get something called as megaloblastic anemia. So you need to differentiate between macrocytic RBCs as well as megaloblastic RBCs. They are not completely matured cell. So when it comes to alcoholism, it will definitely cause macrocytes. It will definitely cause macrocyte, and it is not going to cause microcytes. So if the question is going to be most common macrocytic anemia in India, or if the question is which does not cause microcytic anemia, for whatever the question, alcohol is the right answer, because alcohol will produce macrocytic anemia, alcohol will produce megaloblastic anemia, and in India that is the most common cause. Or when you compare the options, sideroblastic anemia, thalassemias and all, you will have alcohol as the most common cause, because thalassemia is again a genetic defect. So people, let us take up thalassemia here. Now thalassemia is a condition which is manifested by reduction in hemoglobin content. Reduction in hemoglobin synthesis. When hemoglobin synthesis itself is reduced, this will lead to small RBCs. And small RBCs are named as microcytes. So thalassemia will produce microcytic RBCs, not macrocytic RBC. So thalassemia is presented with microcytes, doctors, not macrocytes. And we have Dr. Manoj giving us the fourth option, that is chronic infections. When it comes to anemia of chronic infection, it's a very interesting condition. In chronic infections, people, we do have consumption of iron. We do have consumption of iron, people. Alright, consumption of iron. Now, body iron stores will be depleted. There is going to be depletion of body iron stores. When there is depletion of body iron store, this will lead to, at the early stages, there is going to be normocytic, normochromic anemia. Now, as a later effect during chronic infection, we also see increased production of interleukins, a substance called interleukin 1, interleukin 3, interleukin 6. These interleukins, as well as tumor necrosis factor alpha, these peptides once get synthesized because of infection, they go and suppress erythropoietin. Production. So on one hand, the body is going to be suffering from lack of iron. On the other hand, we are also going to lose erythropoietin. So on the later stage, we are going to see microcytic hypochromic anemia, people. So what started as normocytic normochromic anemia has now turned on to become microcytic hypochromic anemia. So chronic infection is a definitive cause of microcytosis. So guys, in all these conditions, if you put together, you have thalassemia that produces microcytic anemia, chronic infection that produces microcytic anemia. So the only anemia which does not cause microcytosis, the right answer is going to be alcohol. That's the right answer for this question, guys. Fine. Let's move on to the next question. So in whatever question it is, pH is going to be 7.28, bicarbonate is normal, PCO2 is increased, and SpO2 is 82. So let me try to bring it to a common point here. Guys, whatever it is, the right answer is respiratory acidosis. That's the right answer for this question. Now let's try to solve this, guys. You have pH of this patient which is decreased from normal. pH of this patient is going to be 7.28, and partial pressure of arterial carbon dioxide has very much increased, and this is now about 60, or as per some students 70 millimeters of mercury. Normal arterial carbon dioxide is going to be 40 millimeters of mercury, while this patient has got about 70 millimeters, 60 to 70 millimeters of mercury, doctors. Fine. pH, arterial carbon dioxide, bicarbonate values are surprisingly normal. Alright, they have given bicarbonate value in this question. It's going to be 28 milliequivalents, and it is going to be within normal limits. When it comes to saturation percentage of hemoglobin, with oxygen, it is going to be 82%, which is decreased. Normal is about 97%. In this condition, it has been decreased. Now, what is the disorder? Doctors, it is very, very easy. Now, you know how to solve such questions. First, let us take a pH. By looking at pH, what could you able to say? This patient is suffering from acidosis, or is it a case of alkalosis? That's the very first point you got to think. Now pH is 7.28. Now the diagnosis is half done. It's a case of acidosis. Now what you need to do, you got to look at step 2, isn't it? What is step 2? You got to check whether there is an inverse relationship between carbon dioxide as well as pH. Is there an inverse relationship between pH as well as carbon dioxide? Again, you can clearly see here, partial pressure of carbon dioxide is, normal partial pressure is 40. In this patient, you could able to see increased partial pressure of carbon dioxide and pH is getting decreased. So, as per the dictum goes, if the relationship is maintained or no, it is not getting maintained. If the relationship is maintained, definitely it is a case of respiratory disorder. If it is not getting maintained, it is a case of metabolic disorder. In this patient, you could able to clearly see, all right, in this patient, you could able to clearly see you have decrease in pH, increase in carbon dioxide. So the inverse relationship is maintained. It's a clear-cut case of respiratory acidosis. So the diagnosis is over. Now, if at all, if your question has included this, you need to be prepared. Look at step 3, that is checking for bicarbonate levels. Now, bicarbonate levels are perfectly normal, which means there is no compensation. There is no compensation. So if you have option given slightly different, your best answer for this question is uncompensated respiratory acidosis. Uncompensated respiratory acidosis. If at all, if bicarbonate levels are very much increased beyond 28, very much increased beyond 28 milliequivalents per liter. Now your diagnosis will be slightly changed. It is going to be the primary diagnosis as respiratory acidosis compensated by metabolic alkalosis. Respiratory acidosis compensated by metabolic alkalosis. So my dear friends, in whatever the condition may be, either your answer is purely given as respiratory acidosis, or if compensatory mechanisms are getting involved, the right answer for this question is going to be respiratory acidosis, and it is uncompensated. Respiratory acidosis, it is uncompensated as per the value given in the question, right? Now we have a very elaborate video on acid-base balance and how to approach a question of ABG imbalance, completely covered in our app itself. So if you are interested, feel free to use our app and look for that part, how acid-base balance has to be interpreted. We have renal physiology topic in our app, and as a last topic in renal physiology, we would have done acid-base balance. So we had an elaborate discussion how to narrow down your diagnosis to ABG disorders. Everything will be given in a detailed manner. So as for this question paper and discussion is concerned, right answer for this question is respiratory acidosis. Now moving on to the last question, question number 6, pancreatic cell tumor leading to secretory diarrhea. It is very simple, people. We have VIPoma, pancreatic cells produces vasoactive intestinal polypeptide? Alright, vasoactive intestinal polypeptide, which is going to trigger GI motility. And GI motility, once getting triggered, there is going to be increased bowel movements, causing diarrhea, and that is how vasoactive intestinal polypeptide secreting tumor of pancreas is going to leading to secretory diarrhea, doctors. Definitely it is not glucagonoma, insulinoma or Zollinger-Ellison syndrome. In either of these cases, you have different conditions, different secretory products that gets increased. In glucagonoma, you have glucagon level rises, and in insulinoma, you have insulin level rises. Both of them is not going to influence GI motility. In Zollinger-Ellison syndrome, you have very much increase in gastrin. So gastrin is going to influence gastric acid production but not motility. So definitely the right answer for this question is VIPoma. Alright. Now we have a question that's been discussed by Dr. Himanshu Verma. So let me take up question number 7 as you have been discussed in this chat box. One question is there: which enzyme causes conversion of T4 into T3 in peripheral tissues? Conversion of T4 to T3 in peripheral tissues, doctors. Dr. Himanshu, the right answer for this question is, it is deiodinase, an enzyme called as deiodinase type 1. Alright, deiodinase type 1 converts T4 into T3, and this is the most abundant form. Type 1 is the most abundant form in peripheral tissues. Now we have another enzyme. Now this is for your for your understanding, as well as if the question gets extended in the upcoming exams, you got to be familiar with it. We have the second type called deiodinase type 2. Deiodinase type 2 is also involved in converting T4 to T3. Now this is seen in brain as well as thyroid gland. Only brain as well as thyroid gland have got this enzyme deiodinase type 2. So as per the dictum, as we just discussed, which is the most abundant form in peripheral tissues, every single body tissue is going to have type 1 deiodinase. So right answer for this question is going to be type 1 deiodinase, which is D1. That's going to be the right answer. Alright guys. Now when it comes to the third type, we have a third type called deiodinase. Deiodinase type 3. It is going to involve in converting T4 into a T3 called reverse T3. Reverse T3 is biologically inactive as of now. Reverse T3 is biologically inactive as of now, doctors. Alright. So reverse T3 is not going to bring active form of T3. So between options given as D1, D2, D3, the right answer for this question is D1. That's the right answer for this question, doctors. Alright. That's question, as you said. Okay, Dr. Himanshu, your question is also getting answered. And right, infections are all microbiology. 43 prisoners, only 8 survived. Oxygen supply was normal. What is the reason for prisoners died? Physical change in air, chemical change in air. Alright, if the question is regarding this, there is a hole in Kolkata, 43 prisoners, only 8 survived. So we'll take that question as well. In case of carbon monoxide poisoning, it's carbon monoxide, right? Yeah, in case of carbon monoxide poisoning. In case of carbon monoxide poisoning, what happens is, people, the physical quality of air does not change. Physical quality of air is not going to change. Whereas when it comes to chemical quality of air, there is going to be a significant change here, doctors. Let us see what it is. To understand this, you need to know what is normal air composition. Normal air composition. So atmospheric pressure, normal atmospheric pressure is 760 millimeters of mercury, which is made of nitrogen, oxygen, inert gases, which includes argon, boron, krypton, helium, alright, and then we have carbon dioxide. Nitrogen contributes to about 70% of atmosphere, oxygen contributes to 21%, inert gases about 9%, carbon dioxide contributes to 0.003%. Now remember, people, whenever there is a addition of a new gas, whenever there is an addition of new gas into a mixture of an existing gas, this new gas that is getting into the mixture is going to dilute the proportion of each gases. So whenever a new gas is added, to the mixture of gas in atmosphere, what's going to happen? There is going to be a very same total atmospheric pressure. Total atmospheric pressure does not change. That's one very important point you got to understand in this question. Total atmospheric pressure do not change. So what else happens? Partial pressure of every single gas decreases. Partial pressure of every other gas decreases. So as per the question, just because the patient is, just because the group of people are getting stuck within a room and there is too much of carbon monoxide, because of excessive carbon monoxide, partial pressure of nitrogen drops, oxygen drops, inert gases drops, carbon dioxide drops. When partial pressure of oxygen is getting lesser and lesser because of carbon monoxide, the inspiring air is going to have less oxygen. So RBCs are going to absorb lesser oxygen from alveoli, and hemoglobin is going to combine with carbon monoxide preferentially than oxygen. So by every mean, you have a significant drop in chemical quality of air. So chemical quality of air changes, and the death of patient is as per your options, as you just told me that there is going to be physical change or chemical change. And if this is two options, physical and chemical, the right answer for this question is chemical change in air, doctors. So that's the question asked by Dr. Daffy. Yes, that's your question. All right. Remaining videos in endocrine system and GAT. Doctor, I assure you, all right? Dr. RAGS VD, all right? I promise you within 2 weeks, you'll have endocrine physiology as well as GAT in eGurukul lab. That's my promise. You will get that. That's for sure, doctor. All right. Question framing is wrong. I'm very sorry, Dr. Sandeep. I am not the one who attended this examination. Alright, so I'm getting feedbacks from my students who are telling me this is the question that's been asked. So it's not, I'm not extracting the question from your paper and pasting it here. It's the word of mouth that's been receiving to us, and I'm framing the questions on that part. So I can't help it up if the question framing is wrong. That's not my problem. So that's on the other side. And Dr. Sandeep, there is one question on oxytocin. All right, if you could able to let me know what the question is, yeah, I can able to help you with that answer. Anyway, you have my contact in Telegram, you have my contact in Facebook. My dear students, feel free to ask me any doubts if you got in case of the question. If you could able to remember what is the question on oxytocin and other things, all right, IgE and all, if you could able to bring about a clear cut question and options, I'll help you with that, people. So yeah, you have my contact in Telegram and WhatsApp, you feel free to use that. And one question on estrogen cause breast development, axillary pubic hair, endometrial proliferation. D, estrogen will cause endometrial proliferation, no doubt about it. Estrogen is also going to involve in breast development, but between breast development and endometrial proliferation, the best answer can be breast development, doctors. The reason is, when it comes to endometrial growth, the word is quite important, all right? So let me write that too, if possible, all right? So when it comes to estrogen, now I'll tell you the breast development first, and then we'll move on to endometrium. When it comes to breast development, you have 2 points regarding breast development, doctors. Number one, growth of supporting structures. Number one is growth of supporting structures that include fats, that includes ligaments. Number two, when it comes to breast, there is a specific growth of alveolar lobular structures. Lobulo-alveolar structures which are involved in synthesis of milk. The hormone which is absolutely critical for the development of lobulo-alveolar structures is progesterone. And the hormone which is involved in developing supporting structures of breast is estrogen. All right. And for milk ejection, for milk ejection, we need oxytocin, and for milk synthesis, we need prolactin. These are the hormones acting on breast, doctors. So oxytocin, prolactin, progesterone, and estrogen. So definitely estrogen has got a very, very, very important role in supporting structure development of breast. That's very crucial role played by estrogen. When it comes to endometrium, now after shedding, after menstrual phase, once the inner lining of endometrium has been shed due to menstrual phase of menstrual cycle, we have growth of endometrial layer. All right, we have growth of endometrial layer which is caused by estrogen. Fine. And when it comes to luteal phase, we have corpus luteum coming in. Now the first phase where estrogen involves in growth of endometrium, this phase is called as follicular phase. And luteal phase, we have formation of the ovulation is going to bring ovum into the uterus, and there is going to be corpus luteum formation, which is going to produce progesterone. In the presence of progesterone, we could able to see growth of glandular structures. The glands of endometrium is going to grow more, and there is going to be increase in vasculature of endometrium. Now this glandular structural growth, increase in vasculature, as well as there is going to be increase in thickness of endometrium. Now this is exactly what is called as proliferation. So if the question is asked about roles of estrogen in breast development and endometrial proliferation, the better option is breast development. But as Dr. Meghna was saying, the question is about all the effects of estrogen except in, Dr. Sabayachi and Dr. Himanshu, that's okay, very good. So if it is except, all the options are correct, all right. So estrogen is involved in supporting structure development, estrogen is involved in endometrial layer development, estrogen is going to be involved in growth of axillary hair and pubic hair, and all the three are going to be the right answers, and the except, whatever it is, that is going to be your answer for the question, people. So for that question, except is going to be the right answer. So guys, that was our discussion, and that completes our discussion of physiology questions. In case if you need my assistance, we have eGurukul app exclusively. We have our eGurukul exclusive Telegram group. You can contact me in Telegram group. If not, my ID is Prem Balaguru in Telegram. Feel free to contact me in Telegram or Facebook. I'll be happy to help you guys out. That's it, guys. My good luck and best wishes. My very best wishes for your results as well. So thank you, guys. Thank you very much.